or if you know a colleague that's unable to join. Thanks, Kate. We'll get this webinar up and live on our website shortly as well. Just a bit of housekeeping, like I say, so if you're not speaking, please ensure that you're on mute. We've got really good numbers tonight, and I know there's a few others that are trying to join over the next couple of minutes as well.
Statement. I don't think, unless
so if you are not speaking, please pop yourself on mute, if that's okay. Just to repeat, so make sure you're on mute, guys.
They've checked it, and then
Nadia, can you put yourself on mute?
Of the full story, and then the witness statements.
Lovely. So I'm just going to do just a bit of a round of introductions for everyone, because I'm going to be supported by a number of our colleagues today to talk about obviously controlled drugs. For those of you that don't know me, and I hope you all do by now, I'm Rajshri. I'm your Chief Officer for Community Pharmacy, Leicestershire and Rutland, also known as we were known as the LPC. There's a few of my committee members that have joined as well, but I won't do a round of introductions for them, because I'm sure you're fully aware of who they are and you can see them in the chat. But in terms of our guest speakers, so really delighted to say that we're joined by a couple of our guest speakers tonight, including Amit. Amit, do you want to just say hello, if that's okay? Pop yourself on from mute.
Thank you. Yeah, my name is Amit Dowda. I am a Controlled Drug Accountable Officer for the West Midlands, and I'm BAV's Deputy for Leicestershire, Leicester and Rutland. So really nice to meet you. Thank you for inviting us.
Thanks, Amit. I know Bav is on the call as well, and she's having a few issues. Can you hear us, Bav?
I can.
Fabulous. Do you want to just... No, we can hear you. We can hear you fine. Do you want to just introduce yourself, Bav?
It's really great, and thank you for inviting Amit, myself, and also Catherine from Turning Point. So my name is Bav Patani. I'm actually the Director of Patient Safety and System Improvement, and I am the CDAO for LLR as well as Lincolnshire and Northamptonshire. So thank you, Registry, and I know we've got a presentation which I think you're going to be sharing, and we've got some slides as well. Thank you.
That's brilliant, Bav. Thank you so much. And you're right, Bav, we've got Catherine supporting. So Catherine is on the call. Catherine, can you just pop yourself off mute and introduce yourself, if that's okay, from Turning Point?
Yeah, good evening. I'm Catherine Watkinson, and I'm the Turning Point Head of Pharmacy and Medicines Optimisation.
Brilliant. Thank you so much for joining us and supporting tonight's event. We've obviously got really good interest from our colleagues across pharmacy, including it's going to be a mixture. The event's open to not just pharmacists but pharmacy team members as well, because in some shape or form we all have some kind of dealings with controlled drugs. And I think, you know, as Chief Officer for the LPC, periodically I do receive queries on controlled drugs, and they can be so far and in between. I spoke to Amit just last week about a query which I shared with our contractors or community pharmacists at our open house surgery earlier on this month, which was around whether the prescriber's name needs to be appearing on the electronic prescription, and that for me even was a learning curve as well. So there's always things that we don't know until we actually know, and that's what we find out with controlled drugs sometimes as well. But really pleased tonight that we're joined by Amit and Bav, and obviously Catherine as well from Turning Point, and we're going to be discussing controlled drug regulations and also their implications for pharmacy practice. Now, Amit and Catherine do have a short presentation which we're going to be sharing and we'll be going through straight away. But I really want to, after that, leave it open to allow our colleagues who have joined us tonight to have the opportunity to ask questions and really have a good organic discussion around controlled drugs, particularly in terms of what they're seeing in day-to-day practice. So with that said and the scene set, I'm just going to share my screen. Kate, can you just allow me to share my screen, if that's okay, or to share the screen? Are you able to do that?
Yeah, you should be able to now.
Brilliant, thank you. There we go. So if you just want to let me know when you're happy for me to change the slide, Amit and Catherine, But over to you, if that's okay.
So Bav's going to start. So over to Bav, I think, first. Thank you, Bav.
Yeah, thank you. And if you could go on to the next slide, please, that'd be really helpful, Registry. Thank you. So, colleagues, as we've said, I firstly just thank you on behalf of Amit, myself, and from Catherine to invite us for the session this evening. I did introduce myself, and my full Sunday title is Director of Patient Safety and System Improvement for the region. I work directly for the Regional Medical Director, that's Dr. Jess Sokoloff, and my role entails all things patient safety. And alongside this role, I have kept the role as CDAO for LLR, as well as links to Northampton, and the other parts of the Midlands region is covered by Amit, who's here, who acts as my deputy for LLR, and also by Sam Travis, who you may have met. And as Registry said, the objectives of today's session is to explore the role of CDAOs, what it entails, and to share some of the issues that have arisen from the lens of community pharmacy. And colleagues, patient safety, freedom to speak up and sharing concerns is of paramount importance. Colleagues, the really sad case of Lucy Letby just in the press over the last few weeks has just accelerated and an overnight cultural shift. So Registry, if I could have the next slide, please. So colleagues, on this slide, you'll see some pictures which I hope you recognise. So I just want to share a little bit of the background and the context to why this is important, and why the management and clear oversight of controlled drugs is really important in your own organisations, but for me as well. So GP Harold Shipman, he was convicted of murdering patients. The investigation that had followed a report by a fellow GP who had suspected this failed to uncover evidence. But had those investigations been conducted properly, lives would have been saved. This is going back to 2003. I'll come back to that on my next slide in a sec. And then you've got alongside that a picture of Gosport War Memorial Hospital near Portsmouth. It was over 27 years since nurses at this hospital first voiced their concerns. The report of the Gosport Independent Panel in 2018 shown that concerns were valid and the lives of over 450 people and probably 200 more were shortened as a direct result of the pattern of prescribing and administering of opioids that had become the norm at this hospital. And on the right-hand side, we have a picture of a young lady called Faye. And Registry, I hope we can share the slides and the links to this, but have a read of it. This is the real story told by the parents of Faye and the impact and the eventual death chronic pain management had on her life. And on the back of perceived rises in addiction and also diversion that you've seen over the wider comms of the last few years. So thank you, Registry. If you could go on to the next slide, please. So just wanted to give a little bit of information about the actual reg. So NHS England has a statutory duty to ensure that safe systems are in place for the management and use of controlled drugs. And this is to prevent harm to patients and staff from any misuse of controlled drugs. So the controlled drugs supervision of management and use regulations were initially introduced as part of the government's response to Shipman's inquiry fourth report, and that was in 2004. And the aim was to strengthen the governance arrangements. As you can see, and following the passing of the Health and Social Care Act, various changes to NHS England and architecture, CCG, ICBs, etc., those were updated in 2020. So what do the actual regulations require? They require NHS England and other designated bodies, so that's NHS Trust, hospices, private and independent hospitals to appoint their AOs for controlled drugs. And these require those AOs to ensure safe systems are in place for the management and use of controlled drugs. But all healthcare professionals have a statutory duty to report all complaints, concerns, and untoward incidences involving controlled drugs to CDAOs. For non-designated bodies, such as yourselves in community pharmacies and also GP practices, care homes, drug and alcohol services, and other CD incidences, they need to be reported to a regional NHS England CDAO. So for LLR, that's me. So NHS England CDAOs have responsibilities. Just very quickly, that those include establishing and leading the local intelligence networks for that geography. And you draw upon that representatives from designated and responsible bodies and a registry. As you know, we've invited the LPC and LLR to be a seat at the table for the LLR LIN. We have to convene incident panels, and they need to be of a transparent process. Analysing of NHS and private prescribing of CDs. We need to ensure we protect patients and the public if concerns about inappropriate or unsafe use of CDs occurs by a person. And lastly, and more importantly, promoting good prescribing practice in relation to CDs. So those are some really high-level issues from the regulations. And I'm going to hand over to Amit, if that's all right now, to talk through the next part of the presentation. Registrar, if you could go on to the next slide. And Amit, if you could hop on now, please. Thank you.
Super, thank you, Bav. So Bav's touched on reporting of controlled drug incidents and concerns. Now in LLR, we've used this portal, www.cdreporting.co.uk, for a number of years, and I'm hoping this screen is all familiar to you. Since 1st of December 2022, the portal has been revamped and relaunched, so it looks slightly different to what it did previously. If you have been registered previously on the portal and you've not logged in since 1st of December 2022, you need to re-register yourself with new login details. So if I just go through the portal and what sort of functions it's got, can I have press the next button for me, please? I'm hoping, yes, technology is working, fantastic. So as you can see from the red circle, if you have got a controlled drug incident that needs to be reported, that's where you click into. Controlled drug incidents are incidents such as quantity errors, strength errors, wrong formulations. Next button, please. So with a controlled drug incident, we are looking at what's happened, the contributory factors, actions taken, and really importantly, the learnings and reflections. I can't emphasize that enough. We need the learnings and reflections in the incident. So the next circle is around reporting a controlled drug concern. So this is around when you've got concerns around patients or individuals or prescribers, and you can report these concerns in an anonymous way, so you don't have to give your details. Obviously, details do help in case we need further information, but we leave that to your discretion. The next circle is the messages. So when you report CD incidents and concerns, we sometimes need further information, and this portal now allows us to send messages through this system. So when you log in, you may see messages on there. Please look at it on a regular basis and try and answer those questions as soon as you can. Next button, please. Okay, so this is for destructions. So if you're not part of a pharmacy chain, body corporate of 5 or more, we would sort of send an authorized witness to you to allow the destruction of your out-of-date or obsolete controlled drugs. So you need to fill in that form to request a destruction visit from ourselves. And next button, please. If you press that button, it gives you all the contact details for all the CD accountable officers across the country and their teams. So that's really useful in case you need to contact any of us. And I think it's the last button. Okay, this is a resource center. We do a number of newsletters and other sources of information, which we do send out to your NHS email account. So please look at that. But in case you've missed it, you can always log into the portal and go into the resource center, which gives you the latest newsletters and articles that we shared. Next slide, please. Okay, so I'm going to touch on CD destructions now. It's really important that you have SOPs in place which cover patient returns, your out-of-date controlled drug destructions and obsolete ones, and you train all your team members in terms of how to segregate it and entries in the register. You need to have a T28 certificate for your premises. You'll be pleased to know it's free. It's quite unusual nowadays getting something for free, but it is free and it's valid for 3 years. Please note that you can't destroy controlled drugs unless you've got this T28 certificate for your premises. We'd recommend that you use CD destruction kits to denature controlled drugs. That's for Schedule 2, 3, 4, Part 1. Please read the instructions for these CD destruction kits. They do vary a lot. Some you've got to keep in the CD cupboard for 24 hours, some 48 hours. Some actually release air as well. Some you've got to leave a bit loose as well. just because it can explode. So please read the instructions. Maintain robust records as well. That's really important. Destructions should involve a witness and usually a registered professional and another person destroying the controlled drugs. And please keep up to date with your destructions. Quite often, obviously, if they're not kept up to date, it can cause incidents, errors, and they do get misplaced as well. So please keep up to date with your destructions. We have noticed actually this year compared to last year, we have had less destruction requests. We're not sure why that is. Maybe there's not that many controlled drugs going out of date, but a request from me and Bath, please go into your CD cupboard, check if you've got any out-of-date CDs. If you have, please report them. The quicker you report them, the quicker we're able to help and support you. If I go on to patient return controlled drugs, so just a note here, I'm sure you all know this already, pharmacies cannot accept CDs from nursing homes. We've had a couple of pharmacies previously who have accepted controlled drugs from nursing homes. They should be destroying their own controlled drugs. It's good practice to keep a record of returned controlled drugs and their destruction, preferably in a separate register. You do not require an authorized witness. And what I mean by an authorized witness, it is a designated authorized witness by a controlled drug accountable officer, like myself or BAV, but for LLR, it would be for BAV. It'll be a GPHC inspector or the police controlled drug liaison officer. They're your normal authorized witnesses. Destructions can be completed by the pharmacy team, a witness and the person destroying it. And obviously you need safe custody of Schedule 2 and 3 controlled drugs unless they're exempt. Segregating the CD safe, make sure they're clearly marked as patient returns. Next slide, please. So expired and obsolete controlled drug stock. So it's a legal requirement for Schedule 2 controlled drugs that you need an authorized witness. So I mentioned before who those authorized witnesses are. If you're not a body corporate, then you need to submit an authorized witness destruction request via either portal. And I think it was that green tab on the bottom. If you're a body corporate, more than 5 pharmacies in your chain, you need to follow your organizational SOP. You will have authorized witnesses within your company who are able to witness those destructions. Safe custody should be maintained. CDs should be segregated and clearly marked, just like patient returned CD. Out of date stock. Sorry, just some background noise. I think.
There is, yes. If you could just pop yourself on mute, that would be great, because otherwise we can't hear Amit clearly, and we want to understand what each slide presents as well. Thank you.
Super, thank you for that. So out-of-date stock should be entered in the CD registered and included in the balance. That's really important. We've had incidences where balance checks haven't been done with the out-of-date stock, and then after 3, 4, 5 months, we can't work out what's gone wrong. So that's really important that you maintain those balance checks. And an entry is made into the CD register at the time of destruction as well. Schedule 3s and 4 controlled drugs are destroyed by pharmacy staff with a witness and a person destroying. So you can destroy Schedule 3 and 4 controlled drugs internally. So you don't need an authorized witness for those schedules. Next slide, please. Okay, I'm going to touch on CPCS now, Community Pharmacy Consultation Service. So believe it or not, I was a community pharmacist and patient-facing, and I've done a number of these CPCSs. Fantastic service, in my opinion, using the skills of pharmacists. But like with any service, you do get individuals who sometimes abuse the system. And with this system, controlled drugs, as you would expect or may guess, can be abused. So I'll give you an example. Recently, we've had a patient who's rang 111 for a non-controlled drug request. They've gone into the pharmacy and then they wanted codeine as well. So they've done this at a number of pharmacies a number of times. And obviously it's a pharmacist professional decision, but just be mindful that you would just treat it as you would any other emergency supply. Just because it's been referred by 111 doesn't mean it's okay. So please use your professional judgment when it comes to controlled drugs, and actually, strange behaviors like requesting an additional item when you've not had the information come through from 111. As Bav mentioned before, we do monitor the prescribing of controlled drugs, and that includes CPCS. Now, you probably know this already, but for Schedule 4 and 5 controlled drugs, you can supply through CPCS, but for a maximum of 5 days only. If you supply for more than 5 days, we will pick this up and we'll write to you to your NHS mail account. So please check your NHS mail. If it happens frequently, we will ring you up and make contact. So just for Schedule 4 and 5 controlled drugs, a maximum of 5 days only. We have noticed recently with the data, there's been lots of cocodamol that's been supplied, 56 tablets, 100 tablets, so please be mindful of that as well. Diversion of controlled drugs. So this is not unique to community pharmacy. It happens in other organizations like acute trusts, hospices, care homes. We've had a couple of incidents, and I think it's worth sharing the learning as well. We've had one incident where healthcare assistant's been really helpful to the pharmacist. They suggested to the pharmacist that they'll do all the ordering for the pharmacist, which I think is really helpful, isn't it? And who would knock that off really? So anyway, this healthcare assistant used to order Schedule 4 and 5 controlled drugs in quite large quantities. When the delivery driver came to deliver the boxes, she used to intervene and take the Schedule 4 and 5 controlled drugs out. We've had other assistants who've sort of diverted Schedule 4 and 5 controlled drugs as well. The learning, I think, is that when and if the pharmacy did a DBS check, they might have sort of noted some information which may have helped in terms of the employment checks, etc. So we'd recommend that if you're employing people in individuals, do the DBS checks. Really, it's really important. You would know that codeine linctors is quite sought after. It's a craze from America that people are using codeine for purple drank and also Phenergan liquid. So please be mindful of that. We've had some incidences across LLR where we had gangs and individuals targeting pharmacies. If you get any incidences like that, please report it to us as a concern. We have got links with the police, CDLOs will come and help and support you. Fraudulent prescriptions. So this is really sad. Unfortunately, we do get healthcare professionals attempting to get controlled drugs by fraudulent prescriptions. I think with EPS, I think things have got better really in terms of when I worked as a pharmacist, you get these handwritten prescriptions and people changing quantities or adding diazepam and stuff. I think with EPS, it's really helped in that respect. But individuals are using different methods and different tactics. So something to be mindful of is private prescriptions. We've seen a surge in fraudulent private prescriptions for lower schedule controlled drugs. So please be mindful of that. And again, private prescriptions for codeine is quite common at the minute. Next slide, please. Okay, balance discrepancies. So the one thing I think which would really help with balance discrepancies is doing the regular balance checks. We have had a number of incidences where there's been large amount of balance discrepancies, and the root cause is really that balance checks haven't been done on a regular basis. So sometimes it's been 4, 5, 6 months where balance checks haven't been done, and then it's really difficult to investigate what's gone wrong. So I'd urge you to make sure you do balance checks as per your SOPs. Another common theme we've had is around dispensing errors. It's quantity errors, it's the LASA drugs, that's a gabapentin and pregabalin. That's really common. Learnings are make sure the stock's segregated, make sure it's double checked by the dispenser and the final checker as well. That's really important. And the other thing we've picked up is modified release and immediate release. Mainly methylphenidate. There's so many formulations out there, aren't there, for methylphenidate? And same with morphine as well. I'm not surprised that these mix-ups happen, but I think if we are aware of it, we will help prevent them. I'm going to stop there now, and I'm going to hand over to Catherine from Turning Point, because we're going to move over to methadone. Thank you very much.
Yeah, hey everyone. So I'm Catherine, and I think some of you have probably met my colleague Mohammed, who works in the Leicester service. So I'm one of the national pharmacy team for Turning Point, and yeah, Mo's asked me to kind of come and deliver a few different sections. So we're going to look at the Home Office appropriate wording and a appropriate date, processes for lost prescriptions, communication between Turning Point and pharmacies, because I know that can be a challenge, and then the 3-day rule and titration dose rule, and then we've got kind of a bit of a case study that we can discuss towards the end. Can I have the next slide, please? So the Home Office approved wording, I know this can cause quite a lot of concern and debate, especially around kind of bank holidays. We're seeing a lot of kind of unplanned pharmacy closures at short notice for various reasons. So all of the MDA prescriptions from Turning Point do have the Home Office approved wording on them. So that allows the dispensing on the day prior to the closure. So for example, if it's a bank holiday and you close on a Monday, but you're open on Saturday, I think we've got someone not on mute.
Sorry, can you just put yourselves on mute, because we can't hear Catherine? So please do, if you're not speaking, pop yourself on mute. There will be the opportunity to ask questions at the end. Thank you. Sorry, Catherine.
No, that's okay. So, for example, if there's a planned closure, so prior to a bank holiday, fortunately we've not got any for a little while now, that allows the dispensing on the Friday or the Saturday, whichever's the preceding day that the pharmacy's open. We're also seeing it more if, for example, you know that there's a day where there isn't going to be a pharmacist available. It does give the option of dispensing it the day prior, that additional dose. And I know there's been a lot of debate around providers in general, because some providers don't put that on every prescription. We put it on every prescription regardless of whether we think it's going to be needed. So for example, if we know that we're sending someone to a pharmacy who's open 7 days a week and is able to provide supervised consumption 7 days a week, we will still put that wording on so that it is on there for every eventuality, rather than, you know, to try and make it easier for the pharmacies. Can I have the next slide, please? The appropriate date, again, at Turning Point, we do batch signing. So quite often our prescribers will be signing the prescriptions away in advance of them. And especially because, as you know, we will post our prescriptions out to pharmacies. So there's quite often a fair lag between us signing a prescription and it getting to the pharmacy. So we use the appropriate date. So as you'll see kind of on this example, the prescription's been signed in August, but the intention isn't actually for that prescription to be until September. So the appropriate date is the date on which the prescribers indicated that they want that to start, which will sometimes mean that the signature date is quite over that 28-day limit, but the approved date is still there and is still valid. Next slide, please. Lost prescriptions. So one of the things that as a provider with other providers, we are working very hard with the Department of Health is to try and get the development done on EPS so that we can have MDA prescriptions done through EPS, which will hopefully solve a lot of the problems that we have. Currently, we rely on Royal Mail track deliveries, and especially during the Royal Mail strikes, that did cause a whole host of problems. So we have taken as many measures as we can to kind of try and make sure that that is as seamless as it can be. So we've made sure that all of the envelopes are addressed to the pharmacist, because we know that especially where you've kind of maybe got a pharmacy as part of another store, it was getting kind of left in customer services and various places that was causing issues. But we ask that when you receive the envelope, if you can check the contents and notify us straight away if there's anything that's missing, if you've got a prescription for someone you weren't expecting, or if there's a prescription missing, and there is a receipt. So if you can return that to us so that we've got that log to kind of track each prescription. if a prescription can't be found, we've got our postal tracker, so we can track that down. And if it's lost at our end, or if it's lost kind of in transit, then we will do the notification for the CDAO, and we'll generate the replacement prescription. What we do see sometimes is that we'll have a returned receipt, or even we know that a dose has been dispensed on a prescription, but then we'll get a phone call to say that prescription's been missing. So we will ask you to double check that it can be found, because a lot of the time it does turn up somewhere. But if not, we will ask you to notify the CDAO, and then we'll look at issuing a replacement. We have a separate process for scenarios where we've got reason to believe a prescription's been stolen, for both blank and written prescriptions, and that kind of includes CDAO and the police. So we've got kind of that element as well, if you've ever got a concern in that regard. Next slide. So, and again, I'm aware that communication can be an issue with both kind of services trying to ring us, and the drama of being put on hold or not being able to get an answer. And equally, I know pharmacies are very, very busy, so sometimes we'll try and ring a pharmacy to pass on a message and we can struggle to get a response. So there is a direct dial, because I know one of the challenges with Turning Point is if you try and put us into Google, you'll come up with our central phone number, which can be a bit of a disaster to try and get a response from an actual person. But in addition, Mo has set up WhatsApp groups with some pharmacies, which seems to be working really, really well. So obviously we wouldn't want any patient identifiable information being shared in that way. But if, for example, you've got a client who's not come for 3 days or is during titration, has missed a dose, if you've seen a client and you've got a particular concern about them, and equally, if we need to get a message to you and we've not been able to get an answer on the phone, it's just a way for us to say, oh, actually, can you give us a ring, or can and I know the feedback's been that for the pharmacies that have used that, that's been really, really helpful. So if that is something that anyone's interested in, I'll share Mo's email address at the end, and he can get that set up. Next slide, please. So missed collections. So I've kind of split this into two. So during titration, if someone misses a collection on the day of a dose increase, do not dispense the prescription and contact Turning Point. And that's due to the risk of death during the induction. We do purposely try and make the increments of doses not fall over a weekend, so that titration only happens during the week when there is someone available at Turning Point to kind of deal with these scenarios. When someone's out of that titration phase and they're on a stable dose or a reducing dose, if they miss a day, indicate on the prescription that dose hasn't been dispensed, and then also annotate that on NEO. If someone's missed 3 consecutive days, don't dispense the prescription and contact Turning Point and note any discussions that you have with us on the PMR. If someone misses 4 non-consecutive days in a 2-week period, and we do know that we've got clients who know the 3-day rule, so they will always kind of push it and do it just enough to stay on that prescription. Dispense the prescription, but if you just inform us so that we can be aware and potentially pull that person in for a further prescribing review. Next slide. So this is a case study that Amit shared, which isn't from a Turning Point service, but is something that we see frequently, or kind of variations of this, which is when it comes to collection by a patient representative. So I'm going to work through this case study, and then obviously there'll be the opportunity for questions at the end. So the patient's relative is collecting the methadone due to health problems, and there's a quantity of over 5 litres involved, but there's no confirmation that the patient's received it over a 3.5-month period. The patient wasn't engaging with the drug and alcohol service, and the key worker wasn't having any communication with them. The pharmacy supplied methadone to the patient's relatives because the representative was presenting sign notes every day. It's alleged that the patient was actually outside of the country during this time, and the relatives were collecting the medication and then claiming that it was being sent abroad. On return to the UK, the patient was admitted to hospital, where during the medicines reconciliation process, the pharmacy were contacted. And that's how it came to light. So we do have processes in place for collection by a patient's representative. I think especially during COVID, it became fairly necessary at times, and there is the process of sign notes. And again, when it comes to supervised consumption, there is the option there with communication with the prescriber to be able to give that to a representative, because the supervised consumption isn't kind of a legally binding element of the prescription. So in conjunction with a discussion with Turning Point, that could happen. Next slide. So after the case came to light, the pharmacy were contacted the Drug and Alcohol Service, informed them that the patient was in hospital, and then the prescriptions were voided and the methadone supply stopped, which then resulted in a review of the process from the Drug and Alcohol Service, and also a discussion with the patient. And the police were made aware of the incident with the potential diversion of the controlled drugs. Next slide. So the outcomes were that the excess was returned to the pharmacy for disposal. I think quite importantly, there was a review of that service level agreement and the operating procedures to work out how that was kind of allowed to continue. And also the Drug and Alcohol Service reviewing their internal processes to assure that it's approved by the prescribing team. And I think from Turning Point's perspective, we have processes in place, and I think if at any point you get methadone that's being collected by a patient representative and there hasn't been a communication with Turning Point to kind of conversation with us, even if, you know, and it's always difficult, isn't it, to work out whether something is or isn't genuine, but to make sure that we're kind of aware of that, because I think, you know, if certainly if it goes on for a long period, we want to know, and we'd want to have kind of sight of that patient and to be able to review them, and again to support our pharmacy colleagues in being able to support that individual. Next slide, I think. Oh, learning, yep. So ensuring that all members of the pharmacy team are aware of the SLAs in place, and that they've understood the process for substance misuse patients. Documenting those conversations in the PMR, and I know unfortunately kind of in my role, investigating when incidents happen, occasionally having to pull things together for the coroners, it really is a huge help when that's documented in the PMR and covers from a kind of professional point of view everyone involved to kind of show what actions have been taken. Requests for medication to be collected by patients' representatives need to be time limited, and double check every time a patient's medication is requested by a representative, including how long the arrangement is in place for and any factors that need to be considered. And again, I know that during COVID, you know, we would be able to say, certainly in the early stage, that it would be for kind of 10 days or 14 days. I know it's not always quite that clear cut, but making sure that we've kind of got that plan in place and that's reviewed and again clearly documented. And again, an action for kind of us as a provider, I think as much as anything, is contacting that individual to ensure that they are taking their medication as prescribed, that they have got access to safe storage, to naloxone, and making sure that all those kind of safety measures are in place. Next slide. So thank you. I think, as we said, there's going to be time for questions, and I've put Mo's details on the slide for the service, but equally happy to share mine in the chat as well.
Thank you. Thanks, Catherine, and thank you, Amit and Bav, for that. Just bear with me while I come back out of that. So I haven't been able to see the chat, and I'm not sure if there are any questions, but if I can just open that up to who wants to ask a question. I think it's great that we've got Bav, Amit, and Catherine and Mo. I think Mo's on the call as well, joined us tonight. So this is a great opportunity for you as working in community pharmacy, working day to day, to ask any questions, and it's a great opportunity to do that. So if I just open that up to you guys, feel free to pop your hand up and don't be shy. I think there was I can't see any hands up. I'm just trying to familiarise myself with the chat, but there was a comment, just waste carrier license if collecting. Oh, I can't see it now. think it's been waste carrier license if collecting patient returns when delivering medicines. Not sure, there was a question around that. I think that was Tarek. I think if Tarek's on the call, do you want to ask that question, Tarek? We've got a very shy bunch here, guys, so I wasn't expecting that.
Hello, sorry. I was just
Hello.
I was multitasking. I was just doing some family and COVID stuff at the same time as listening. So I had to just put the laptop down. Apologies for that first.
That's okay, no problem, Tarek. We just saw a couple of comments, so I just wondered if you had any questions for.
Yeah, couple of things. What is, I work across quite a lot of sites from Leicester, Birmingham, London, Manchester, etc. One of the things on the CD reporting portal, I was just supporting a superintendent on an incident elsewhere, is around not spillage, but an accidental drop of a bottle. So we've done everything. But what I saw on the portal was we put the incident report in, and when you go into your reports, where it says you can amend or adjust the reports, it's got little tabs, and one of them says action pending, for example, or in progress. Next to that, so the action box has got a tick, no action. So it's a bit confusing when you look at the report, whether it's been actioned or not by the area team or the control drug team. So the report itself can be a bit confusing, especially if it's the first time you've put an incident on the portal, because you don't get a regular occurrence of incidents on CDs.
Okay, so I'm going to registry. If I can hand over to Amit just to confirm, because he has written something in the chat. Just to confirm, the CD reporting tool portal is standard across the country now, so we're all using the same portal. So if you see it in our patch or another patch, we should all be seeing the same. Amit, you've written. I have to say, I'm trying to picture what this means, but when we
what I'm going to do is let me get my laptop, log in.
So
Tarek,
can I suggest you screenshot it like I was suggesting and email it to me? I can have a conversation with the portal team, because the last thing we want to do is cause any sort of confusion, I think, and it's really good feedback. So thank you for that, Tarek. In terms of whether we want more information, whether the incident is open or closed, when you log in, you should see whether the incident is open or closed. So once an incident has been closed, it does change from open to closed.
Yeah.
And
I mean, I agree with what you're saying. It's what you've got is you've got a tab. Well, it's like a table format, and one says open. So your assumption is it's still open, going through review. Yeah. The next tab to it, which says it's got a green tick and says no action. So especially obviously unless you're regularly inputting incidents that are happening, it's been a while since I've done it, seen an incident happen and we put it on the portal. So that's why I'll do a screenshot and send it over to yourself.
You can
just
send
to
it
give you an idea.
Yeah. Send it to registry and she'll forward it on to us, and we'll definitely feed it back, Tarek. Anything we can do to improve the system is good, I think. Yeah.
No, that's fine. And then the second question I think I put on was regarding, I know a few years ago, whether it was during COVID or just before COVID, one of the NHS inspections elsewhere, this topic came up, where if you are providing a delivery service to patients, for example, and you then, let's say you've done a delivery to, could be a housebound patient, could be any patient, they've got some patient return. Is there a requirement for a carrier's license for you to be able to carry that back from the patient home to the pharmacy? I remember once we had to take one out. So it just came to mind, and I've asked the question. So somebody may know the answer, may not. I'm going to look at it tonight. It's been a long while since I've looked at it.
Yeah, my understanding is that, and I think registry might want to just check with CPE actually, just to get that definitive answer. But I would assume that pharmacies would be exempt. But like you, Tarek, I've not looked at it for a number of years. Maybe registry, you could just check with CPE just to get that confirmation, because I think it applies to things outside CDs as well. It's not just for CDs. It's for all medicines,
that's right.
isn't it?
Yeah, it's like patient returns, because you see, if you deliver and then you pick up a return, potentially, I've got a law background. You could be a carrier. So I'm going to double check. It's been years since I last looked at it, and I know we had to take you out a while ago. And I know with COVID sites, it's a requirement if you're doing offsite, because I had that during the COVID period, where if you've got roving clinics or offsite, the CCG in the last phase requested a carrier's license.
Sorry, Tarek, I'll check with CPPE. That's fine. Leave that with me, and I'll come back to you. Can you just I'll pop my email address in the chat for you, and then once I've obviously had that conversation with CPPE, I'll come back to you. But I will need your email address, so I'll wait for the screenshot and I'll forward that on to Amit.
Perfect.
Okay.
Perfect.
Thank you. Just see if there's any more hands. Gareth, you've got your hand up. Hello.
Hello, Rashmi, thank you. Can I just inquire, as far as locums are concerned, can a locum log on and register with password, etc., on the CD reporting website? And if there's something to report at a pharmacy that you're practicing in, that report logged by the locum, if you like, or should it be logged pertaining to the pharmacy contractor business where the issue might have risen in?
So go on, Amit. Did you want to come in, Amit?
So I would suggest that would depend on your SOPs. So if you're a superintendent, or you check with your superintendent what the preference is. But Gareth, the locum can report it. Any pharmacy team member can report it, including and the superintendent can report it. So it all depends on what your SOP sort of says in terms of who, it's always good, I think, for the locum to have that discussion with the superintendent. It's good to have that peer discussion to understand what the contributory factors are, what the learnings are, and preventative measures. Does that answer your question, Gareth? Or
I think it does, because if the locum was party to whatever the issue might be, and there's an ongoing piece of work, the locum may not be there when the accountable officer is trying to get in touch. So I was just trying to think that one through in my mind.
I guess, Gareth, on that, there's also the risk that if you're a locum working in that in the field, you might want to keep that, your concern confidential from the pharmacy as well. So, Amit, how would you? And obviously within the SOPs, you've just said it's relevant, based on the SOP. So if you're a locum, and I know we've got a number of locums joined us tonight as well, and you want to, you have a legitimate concern to raise, but you're afraid that it will actually go back to the superintendent or to that, it's registered in that pharmacy premise. How can you assure that there'll be no negative ramifications on that locum as well?
Okay, so I want to hand over to Bav, because she's an expert in freedom to speak up as well. So I think she'll give the right answer.
So Registry, I think there's 2 points here. There's you've been in, you see a balance discrepancy as a locum, what do you do? Amit's right, you discuss that within whatever the standard local operating procedure is, but the question, can a locum report? Completely can. The portal has got a new function now. If there's a confidential concern that you want to raise, and you want to raise that as somebody who raised that concerns in confidentiality, you just tick that button and that will come through, and that will be treated as we would do in that normal way. Registry, we will also at the end of everything have my email address as the CDAO, and Amit does in his patches and Sam does in her patches. Just email us directly if there's concerns around confidentiality that you don't want to you want to raise in a confidential manner. We will treat it with respect. We have a very strict policy about speaking up and doing that. And I understand that as a locum, and you're on your own and you don't know what to do. And Registry, I'd like to say we do get confidential concerns like that, and we treat them as we do. My other hat on registry for the region is the operational lead for Freedom to Speak Up for the regional medical director. So I'm really keen that we manage those concerns. And Amit, we've got the button now, haven't we, on the portal that allows you to raise concerns in a confidential manner. Amit, is that correct? Would you think that's fair?
Yeah, so there's two options. You can report the concern without any names and details, or you can report the concern with your name and email address, but then tick the box that I don't want to be contacted as well. But again, you could sometimes we need to contact the reporter because there might be just one or two follow-up questions we need to ask, so we can then instigate or carry out an investigation. Really, it's up to the individual and whatever they feel comfortable with. But just to assure you, it does get treated confidentially, and we do triage the information and we do take it seriously.
And not to an extent that will cause detriment. Registry, it's really important.
Yeah, brilliant. Thank you, Bav, and thanks, Hamid. Thank you for giving us that information. Particularly, I think that's really worthwhile because, like I said, we've got a number of locums that have joined us tonight as well. I'm just going to see if there's any more questions or any comments. I know I think I saw a hand up from Rahul, but I don't know if Rahul's still here. Oh, Rahul, there you are. Do you want to just pop yourself off mute?
Hi, yes. It was mainly with regards to authorized witness and how would one become an authorized witness for a company? And if I'm a witness for one company, is it possible to be an authorized witness and do it for another company as well?
Okay, shall I answer that one, Bav? Yeah.
Yeah, no, please take it away, Amit.
Okay, so Rahul, so I'm assuming you've in your pharmacy chain you've got 5 or more in the same limited company, and if that's the case, what I suggest you do is you email us. I think the email was on the last slide, and I can have that discussion outside the meeting because I just need maybe some information from you, probably better outside this meeting, if that's okay. But you can become an authorized witness, and you can be an authorized witness for multiple companies as well. But we'll have that discussion outside the meeting.
Okay, sure. Thank you.
Yeah. Brilliant. Thank you. And I'll try and put that email in the chat as well before close of the webinar as well. Sorry.
Just to say, so to become an authorised witness, it has to be approved by, for situations like Rahul's, there needs to be an authorised signatory, that certificate that we go through a due diligence process, and there's a standard operating procedure that we use, and then there's a certificate that I will sign, or Amit will sign for his AWs, and Sam will sign for hers. So we go through a process, but there are lots of questions and due diligence that we need to do. So as per process, please contact the CDAO team, and that we can go through that process. So it's not as if it's a secret or anything, it just needs to go through process to be able for me to authorise that signatory as an AW.
Brilliant. Thank you, Bav. Thanks, Amit, as well. Reggie, did you want to come in? I don't know if you've got yourself off mute.
I thought you would be in person. It's not. It's
maybe not. Okay. Reggie, did you want to come in? No. Okay, that's fine. Are there any other questions or comments from anyone? Just want to make sure everyone's got the opportunity to ask or raise any concerns or queries.
Registry, you should be on the list for the next LIN meeting that's coming up soon. So if there is anything after this that people email you once they've reflected or thought through, please bring them along, and we'll try and talk them through when you come. It's sometimes people need to reflect, don't they?
We do. No, that's brilliant. That's a fair point, Bav. Thank you. I guess one of the things I picked up today as you were presenting more on Amit's slide was just around, and during the case study as well, because I thought that case study was really interesting, because there was a number the sequential pitfalls, I guess, and I mean that with the deepest respect, because it's very easily done, and particularly in having worked in pharmacy myself as well. But thinking about the signed notes as well, that just seems rather, considering where we are in 2023, it just seems really outdated in today's world. And I wonder if there's any, review on a national level. I mean, you're both nodding your head, and I'm glad that's the case. But is there any, anything in the limelight, in the future, whereby that will be reviewed or looked at? Because we have you know, you think about some services where patients come in with unique identifying codes, and you know, we're not dealing with controlled drugs in those situations. You know, but obviously we're dealing with prescription-only medicines. But surely there's a better way of doing that in today's world.
So, Catherine, I don't know if you want to come in, because obviously it's probably more to do with the SLA, and obviously I know you touched on, you know, supervision not being a legal requirement, and I suppose the notes aren't a legal requirement, I suppose. But anyway, Catherine, over to you.
Yeah, I agree. I think part of the challenge at the moment is that because our systems don't join up, it's very difficult for us to have anything that's kind of, I think, more, I don't know, one, more kind of tamper-proof, and two, that's more like electronic and not as, you know, because there's obviously a note is easily forgeable. It's not, you know, it's not even a formal document. I think there's been a lot of frustration, certainly from myself and other providers, that we'd been told that the EPS development was going to be starting next year. But our latest update has been that due to, quote, other ministerial priorities, it has been shelved, not paused, shelved. So we're currently in the process of kind of lobbying for that to develop. And because one of the things that I think there could really be the potential for is that then it would make it all a lot more real time. So things like 3-day rules, making notifications about changing prescriptions, that would all be that much kind of safer, I think, as well as easier. For me, there's a real big safety issue with the way that we have to do things currently. So yes, I think there needs to be a better way. I haven't got an idea for what that could look like as it stands, but I think the thing that kind of, you know, both from, I know, conversations I've had with Amit, both here and in some of our other services, and just generally as we look into incidents, that I think the key to a lot of this is communication. And you know, and it's the nature of kind of the services we work in, that everything's kind of stripped back and everyone's kind of doing the jobs of 2 or 3 people, but it actually makes it really, really difficult for people to have the time to pick up the phone. But I think it is still really, really key, and certainly when Mo was sharing with me around this WhatsApp group, that's something that I've kind of suggested to other services, because I think anything that, you know, means that from the 1,000 phone calls that happen a day, when you don't quite get to it in time, to then know that, oh, actually, no, that is someone who really needs to speak to me, and, you know, as soon as I have got 30 seconds, I'll do it. I think, yeah. So no, there's not an immediate solution, but definitely something that I'm really, you know, really, really keen to explore any alternative, because I agree. I think it does feel quite archaic.
Yes, no. Well, that's and you know, by all means, I'm not looking for a solution. It's just good to know that actually, you know, we're all kind of echoing the same view as well, and we believe in that there's probably a better way of doing it in modern way. And it's fortunate that it's been shelved. So we shall anticipate that. From an LLR perspective as well, we're also looking at shared care record access for community pharmacies as well. So that pilot, it might be worthwhile you knowing this, Catherine, and I'll catch up with Mo during our regular quarterly catch-ups as well. But shared care records pilot will be rolling out at our AGM on Friday. So we hope to have a pilot going, so that through shared care records, there might be some, I guess, local initiative that we can develop to see whether there's any benefits in that as well. So I'll touch base with Mo after today's webinar, just to keep him in the loop on that. So thank you. I can see a couple of things in the chat. Just to remind you, the webinar is being recorded, so that will be on the website shortly. Not tonight by all means, because we're all going to go back to our families and do what we need to, but it will be certainly there by the end of the week. So we'll let you know through email. Now I'm just conscious it's just over 9 o'clock, and I just want to make sure there's no other questions and just give you the final opportunity to ask our experts who have joined us tonight. So I'll just leave it back open. Just quick last one. If anyone's got a last question, if you want to raise your hand, feel free to. No? Okay. Well, I'd like to take this opportunity to thank both, well, all of you for joining, but in particular, Amit, Bav and Catherine for joining us tonight to present and share those learnings and share deciphering the world of controlled drugs as well. I know it's not easy, particularly given the pressures that a lot of our pharmacies are under. But it's really important, just to reiterate what Amit and the team have said tonight, is that you do have the opportunity all the time to feedback your concerns through the methods in terms of the CDRX reporting portal as well. And we'll share that in the slides, of course. So thank you so much for joining. Feel free to jump off and I will share the contact details of everyone that's joined tonight through my wrap-up email, which will be coming out later in the week. Thank you. Thanks, Amit. Thanks, Bav, and thanks, Catherine.